Good morning. I'd like to open our 14th annual FlowTex 2021 virtual meeting. As the pandemic rocked our lives in 2020, the scientific community adapted quickly and began to form global collaborations to make progress in our field. Many were able to shift their focus to work on SARS-CoV-2 research in both academic and clinical settings. It was inspiring to see researchers sharing data and working toward one common goal, and for that we are grateful. FlowTex is an associated society of cytometrists that organizes annual meetings for our user groups. Our annual meeting is traditionally comprised of both clinical and research sessions. FlowTex 2021, although slightly modified, will begin as always with our clinical session and then shift our focus toward educational sessions and conclude our meeting with our keynote speaker, Dr. Florian Marr. We will meet from 9 to 1:30 Central Standard Time today and again tomorrow at the same time. Our meeting will be presented by experts in flow cytometry whose topics are organized by the following panels. Sample prep will be presented today with panel design and data analysis presented tomorrow. Each panel will end with a roundtable discussion with our speakers so they can answer questions you can submit through YouTube, Twitter, or email to flowtex@flowtex.org. We will have drawings at our midway break and at the end of each day to raffle off $100 gift cards to your choice of Amazon or Grubhub, so keep tuned in during the breaks. The drawing at the end of the meeting will be awarded with $250 gift card, and then we will raffle a final $200 gift card for attendees that complete our post-meeting survey by the end of day Monday. Please be sure to be active in the chat and ask any questions you may have for our speakers. Last year, through a sponsorship from BD and hosted by Science, FlowTex was able to invite global leaders in cytometry and infectious disease to present the role that flow cytometry played in identifying biomarkers as an indication of COVID-19 severity and their role in determining treatment. When planning began for our 2021 virtual meeting, we were met with the opportunity to present part 2 to our science-hosted webinar that will pick up on findings after April 2020. After our second speaker this morning, you'll follow the link to our science-hosted webinar for this session. After the science webinar, we'll continue on YouTube to our speaker panels. If you have any questions or problems during the conference, submit them through YouTube chat or send them to flowtex@flowtex.org. Now, I would like to start our clinical session by introducing Dr. Bruno Brando. Our first speaker is the director of the Hematology and Blood Bank Laboratory at the Western Milan Area Hospital Consortium. Dr. Brando is a founding member of the European Working Group on Clinical Cell Analysis and the European Society for Clinical Cell Analysis, ESCA, for which he also is a former president. He's the vice president of the Italian Society for Clinical Cell Analysis, an associate editor for Cytometry B, serves as a scientific reviewer for Publons, and has authored more than 130 papers in peer-reviewed and medical journals. Dr. Brando's talk this morning is titled Flow-cytometric Immune Monitoring of Rituximab Treatment of Autoimmune Disease. Dr. Brando?
Thank you very much. Thank you very much, and good morning to you all. And thank you especially to Marsha, Karla, and Sarah, with whom I have interacted in the preparation of this meeting, and I'm very honored and pleased to be here this morning. So this morning I would like to talk to you about the immune monitoring of anti-CD20 immunosuppressive therapies that are now widely used in a number of the autoimmune diseases. A flow cytometric monitoring protocol has been recently developed and validated, and I will describe briefly how to use it in the clinical practice. Immunosuppressive treatments have been historically centered on T cells due to the pivotal role on T helper and cytotoxic cells in the immune response. The aim was the restoration of self-tolerance and the development of an immunological reset in the most severe cases, including autoimmune response to transplants. However, T-cell-based immunosuppressive regimens are often burdened with over-immunosuppression, opportunistic infection, organ toxicity, and cancer. At the end of the 90s, an incidental evidence that the patients treated with Rituximab, the first anti-CD20 therapeutic monoclonal for lymphoma, showed an improvement of the concomitant rheumatoid arthritis, has prompted a complete revision of the immunosuppressive scenario with the development of regimens based on B-cell response. As you may recall, B cells are characterized by an ordered sequence of appearance and disappearance of surface and intracellular markers during their development. As you can see, the red stripe, CD20 is expressed from the pre-B stage 1 to the marginal zone mature B cells just before the differentiation to plasmablasts. In autoimmune disorders, the presence of autoreactive antibodies has long been the indicator of the ongoing immune processes. In systemic diseases and organ-specific diseases, one may find different types of autoantibodies that can be also admixed each other. The major problem with autoantibodies is that they are not always correlated with the disease activity grade, so one may question on their actual pathogenic role. And by hitting CD20 B cells with Rituximab, one hopes that the memory pathogenic cells bearing the IgG surface antibodies can be eliminated, since they are the shrine of the autoreactive antibodies. So that's a hope that this may occur before such cells differentiate into terminal plasma cells. Well, many patients with autoimmune disorders stay in a gray zone for years, and some of them are not always properly diagnosed because clinical situations may overlap. Now there is underway a complete revision of the way we are used to diagnose autoimmune disorders by studying the molecular signature of the underlying disease, so without taking in attention the organ toxicity and the organ damage. So it's a complete release of a new scenario and a new diagnostic protocol. So all the major anti-CD20 therapeutic monoclonals do the same job on maturing B cells. Here is depicted just one little semantic distinction between plasmablasts and plasma cells. Plasmablasts, early differentiated terminal memory B cells, are short-lived plasmablasts or long-lived plasmablasts, and they may be found also in the circulation, whereas plasma cells are terminally differentiated and stay mostly in bone marrow and terminal organs. Well, using monoclonal antibodies is a big cytometrist's task. So the cytometrist must be involved in a number of prerequisites of the analysis that can be clearly present in any instance. So when using a therapeutic monoclonal, the target antigen must be present on the right cell subset, and the positively stained cells should then disappear. And this appearance should be clearly distinguished from antigen modulation, that is a typical escape phenomena of cells hit by a monoclonal. So we have the means to do this distinction, which is very important because escape phenomena like antigen modulation or internalization are typical of situations in which the target cell resists the treatment by the antibody. So there is now a big number of therapeutic agents acting mostly on activated mature B cells, whereas when we are willing to treat more differentiated B cells like plasmablasts and plasma cells, we have a relatively restricted repertoire of drugs and we must use basically the same drugs that are used in the treatment of myeloma, like proteasome inhibitors or anti-CD38. So anti-CD20 monoclonals act on their targets with at least 4 different mechanisms. The 2 major mechanisms are complement-dependent cytotoxicity, CDC, or antibody-dependent cell-mediated cytotoxicity, ADCC. But more recently, 2 other mechanisms have been discovered, namely the phagocytosis mediated by polymorphonuclears and macrophages, or a direct apoptotic mechanism induced by the antibody itself. So all these mechanisms are strictly dependent from the interaction between the Fc portion of the bound antibody and the Fc receptor on cells. So the Fc gamma receptor family is very complex, and the majority of those receptors convey activatory signals within the cells. We must take care of just one of this family, the Fc receptor 2b, the CD32b, that is the only inhibitory member of this family that conveys suppression signals into the cell. So the CD16, that is the most important Fc gamma receptor type, type 3, is used by the majority of effector cells, mostly NK cells, and is functionally very active. However, a genetic polymorphism of CD16 has been demonstrated, which results in a different receptor expression according to its zygosity. The VV zygosity, homozygosity, subjects have the highest CD16 density and activity, and this occurs in maybe 10% of people. Heterozygous subjects have an intermediate activity and density, whereas homozygous FF subjects, that are the majority of adults, have a low density and a reduced activity. These differences may at least partly account for a large individual variability of response to rituximab, since the CD16 expression density is linearly related to the ADCC efficiency, as depicted in the lower row. This can be evaluated by flow cytometry, studying the CD16 quantitative expression on NK cells before a treatment with rituximab is started. So what is very impressive is the usage of anti-CD20 in immune-mediated disorders is now absolutely very popular, and new indications in various diseases and medical specialties are being continuously updated. This means that many different medical specialists now use rituximab and other anti-CD20 molecules, and may take advantage from a standardized and rational immune monitoring by flow that can help them to guide the therapy. Well, when we hit CD20 positive B cells, we can do the right job in terms of immunosuppression. So we eliminate antibody-producing cells, but also we can cause some damage, or because not all B cells are nasty, of course, some are regulatory subsets like B-regs, CD5 positive, CD25 positive IL-10 producing cells. And there are also some questions, some open questions on this matter, because peripheral B cells may just partly reflect what's happening in the terminal organ, and things occurring in the terminal organ can be also occurring at a different pace, as we can see in the peripheral blood. And a major question is also that if we hit just one mechanism of action in the complex scenario of autoimmune disorders, maybe we are not doing enough. Sometimes we may need multiple steps and multiple actions on more downstream actions to take full control of the autoimmune disorder. maybe someone may recall that some T cells do express a little CD20, not all, of course, but such cells are equally hit by the anti-CD20 monoclonals. And this could be another mechanism, another side mechanism of treatment with anti-CD20s. And moreover, if we disrupt the accumulation of B cells and plasmablasts in the terminal organs, we can also change the interactions that take place between T cells and B cells. So in the long term, also a favorable scenario of regulatory B cells and of regulatory T cells also takes place in patients receiving anti-CD20. We have mentioned that there are several types of anti-CD20 monoclonals, namely Rituximab, Ocrelizumab, Ofatumumab, and so on. And those antibodies, despite hitting the same target, they are actually different drugs because they have been engineered in the affinity and features of the Fc part especially. So they have different half-lives, as you can see here, and each one is characterized by a different polarization of the different cytotoxic function they can display. So one may also choose between them, among them, to find out the more convenient type of action that may be required in certain diseases and in certain stages of the disease. Well, we can skip this one, not very important. Well, it is important, on the contrary, to appreciate by a cytometric technique what is the real disappearance of the target cell from what is the simple modulation. Here you can see a patient treated with rituximab in which all types of B cells are totally absent. Absence, of course, as expressed with a high-resolution flow cytometry, not a simple ordinary phenotyping. Conversely, in this lower row, you can see a modulation phenomenon, that is, the reappearance of incompletely expressing, incomplete antigen expressing B cells, like CD22 positive cells, CD20 negative or CD24 negative cells. That is modulation. Modulation can be strictly discriminated from disappearance, as you can understand. Well, the early experience of rituximab in rheumatoid arthritis and other autoimmune disorders, you may have heard beautiful presentations by Andy Rostrom last year. This early evidence has shown that the earliest you get rid of B cells, and if you can get the complete depletion after 2 weeks of treatment and no plasma cells or plasmablasts are detectable in the circulation, the prognosis may improve. And this is maybe the first evidence of the good biological effect of rituximab. However, talking about cell disappearance or cell repopulation is another pair of shoes. The cytometric technique may make the difference. So if you use a high-resolution flow cytometric technique, maybe your scenario can change a lot, and the variability related to the first attempts of monitoring can be much reduced. So as a general recommendation, now you must use high-resolution flow cytometry because the number of relevant cells are so small that you must use a very sensitive technique by acquiring millions of cells instead of tens of thousands. Okay, maybe the medical literature is very concurrent in indicating that the disappearance of memory B cells and the repopulation by naive B cells is a good sign of a favorable clinical response. And this has been certified in maybe all autoimmune diseases, and also in allogenic transplantation. So allogenic response may share many of the features we have now under discussion with autoimmunity. So it is interesting to see that all the medical specialties are concurrent in indicating this feature, the cytometric feature, as a favorable sign in patients treated with anti-CD20. Well, some people using a maybe not very appropriate cytometric technique may say that below 5 B cells per microliter is already a disappearance, and reappearance, on the contrary, is after 5 cell microliter is reached. Well, we think, and not only ourselves, of course, think that this is already a too high threshold, and disappearance should set maybe 50 times lower, maybe at 0.1 B cells to state an operational disappearance. And we have several demonstrations of the proof of concept that memory B cells can be damaging. This is a paper in which memory B cells, especially IgG switched memory B cells, can accumulate in the inflamed joints, in the joints of juvenile rheumatoid arthritis, and they produce anti-nuclear antibodies. And also that IgG switched memory B cells are more rapidly repopulating in relapsing patients with nephrotic syndrome. As you can see here, also IgM memory B cells may do the same job, at least without such a large difference as compared to non-relapsers. But this is a matter of discussion, and we will discuss about this later. Interestingly, Rituximab can be used to get rid of anti-HLA antibodies in transplant recipients, and the usage of Rituximab in solid organ transplantation may pose additional problems to the cytometrists engaged in the analysis of flow-cytometrics cross-matching. Well, looking at the sequence of maturation of B cells require a complex recipe of antibodies and markers to see all the maturational steps of B cells. In this recent paper, we see that in the peripheral blood, the first 5 maturational steps of B cells are almost absent, whereas only transitional B cells start to appear in the circulation, and the maturation can be followed until the differentiation into plasmablasts. What is impressive from this slide is the very large CV of normality in the more mature steps. And this is a rather complex 9-color immunophenotyping process. And we can a little criticize this panel because it is shifted to the left of the maturation sequence. So it is most related to the early steps of the B cell maturation. And we can choose how to focus our panel, more to the left or more to the right. This is another example in which a more right-shifted panel can be devised. And this is the panel devised by Rita Carsetti in Rome, which includes all the IgG, IgM, and IgD expression on B cells. So you can differentiate memory B cells into IgM memory and into IgG memory switched, along with transient and plasmablasts. Well, why we are interested in seeing the further maturation of memory B cells? The concept is that memory B cells cannot be enough explanatory for what's going on with autoimmune disorders, because memory B cells are actually very heterogeneous in their composition. We have IgM memory B cells that are cells engaged in the first line defense. They are involved in the innate immune response, are partly spleen dependent and partly spleen independent, and variably depending on the IL-21 in their maturation. Conversely, IgG switched memory B cells are the one involved in the antigen-specific response. They have high affinity with their antigen, and they represent a sort of a deterministic differentiation. So they have passed the point of no return. So they are now engaged with the memory and the permanent memory and the later differentiation into plasma cells. So as you can see, memory B cells are quite heterogeneous and functionally differentiated. And if we use just IgG and IgM, we can take as a remnant the double negative population that is composed with IgD positive and IgA positive cells. And IgA positive memory cells may share some features of the IgG switched cells. Okay, and so this is the protocol that we have recently devised, and this is the protocol that started with a Becton-Dickinson lyotube pre-dispensed, to which we have made add-on with anti-IgM FITC and with anti-IgG APC-H7 as add-ons. And this is a very practical protocol, because just using an 8-color instrument, you have 10 markers, and you must use, for a reliable analysis, the bulk lysis technique. I mean, the lysing of 1 or 2 mLs of blood, massively lysed and washed. So with this method, you can have plenty of cells, especially when B cells are very, very few, but you, of course, are not able to do the direct single platform blood count that requires a blood count to obtain the absolute levels. So the concept is to use the high resolution cytometric analysis using at least 1 million cells, and the B cell subsetting can be evaluated as low as 0.5 cells per microliter, provided you are able to capture 200 or 300 B cells as a cluster. So, and this is the gating syntax and the gating procedure. So the sequence requires the gating with time, and the selection of singlets, elimination of debris, and evaluation of all white cells and lymphocytes. So lymphocytes are now split into 2 different pathways, one using CD3 and CD19 in capturing B lymphocytes and T lymphocytes and having NK cells as a difference. B cells are captured with CD19 and are cleared from contaminants, namely the few B precursors and plasma cells that are subsequently divided into plasma cells by CD27 and precursors with CD38. So once you get CD19 positive, CD20 positive B cells, you can proceed to the B cell functional subsetting by using CD27 and using memory B cells, CD19 positive, 27 positive. You can do the differentiation of the IgM and IgG expression. T cell subsets are then dissected into CD8 and CD4 subsets. And the results is a very complex table, including all the necessary subsets. You have seen how T cells are important in the analysis of anti-B cell treatments. And you must take care of the parent population, because every subset should be related to their own parent population, namely B cells, lymphocytes, memory B cells, and so on. And the gating syntax can be a little complex, apparently a little complex at the beginning, but it's a very robust and can be used for a plain routine, as it happens in our hospital. So all the steps are clearly indicated, and the point is to get at least some hundreds or some thousands of B cells in order to make a proper analysis of the subsetting that can be very, very small in many instances. This protocol, unfortunately, requires fresh cells. So this can be a problem for laboratories receiving samples from outside, and the storage at ambient temperature disrupts almost completely the expression of IgG, whereas the storage at 4 degrees Celsius may spare a little IgG, but not completely. So the message is to use fresh samples as much as possible. And the validation steps have shown that the CVs are reasonable even under the worst conditions. We have very, very low B cell levels, and the virtual absence of B cells with such an approach can be set quite arbitrarily, of course, below 0.1 per microliter. And at this stage, subsetting is almost impossible and probably makes no sense. And repopulation should be taken into account when you see as early as 0.3 to 0.5 B cells per microliter. And in this case, subset can be performed and can be also meaningful in some instances, provided you capture at least 200 or 300 B cells. And the lower level of quantitation, measuring the assay sensitivity, is reproducibly in the range of 0.002%. So a very high resolution flow cytometric techniques. And some patients can display similar levels of memory B cells, but if you go more in detail, you can see a remarkable difference in terms of the IgM or IgG expression. So this further demonstrates that talking about just memory B cells cannot be enough in many instances. So don't stop to the memory cells, but go more in detail, looking at the IgM and IgG expression. And this is the experience we had with a small group of rheumatoid arthritis patients, in which we have made this as a sort of a proof of concept. In this group, 25 patients had active disease, as demonstrated with the DAS28 score. And in these patients, memory B cells and memory switched IgG cells were remarkably higher than in patients in remission. It is a rather limited and I can say dirty example, because patients were totally unselected. They were photographed in a very disorderly fashion, because they had very different medical stories and so on. So this was enough to corroborate our first evidence, but surely requires more experiments to be more suitable. And we can see some patient story, and we can also offer a sort of a protocol also with time points in which we must analyze our patient. So a baseline test in pre-dose, maybe looking at the T cell repertoire, the B cell repertoire, the NK CD16 expression. Remember that rheumatoid arthritis patients and many autoimmune disorder patients are often coming from very, very complex histories of treatment. So the baseline test is very important. So the anti-CD20 protocol is just 1 or 2 doses, and we must have a first check after 3 months. So if we see a complete depletion of B cells after 3 months, we can stay safe and we can postpone the further analysis later, maybe some months later. If patients display a small level of CD19, mostly immature, we must anticipate the second check and be very careful if CD19 cells are more than 1 per microliter, especially if memory cells are more than 50 or 60%. In this case, maybe another cycle of antibody can be considered, or maybe a switch to another type of therapy. This is because patients may have several escape phenomena like anti-rituximab antibodies, or maybe a particularly aggressive disease that is resistant to treatment by itself, or in case of nephrotic syndrome, they have an accelerated clearance of rituximab and other IgG antibodies. So this marked patient variability can be at least partly solved with monitoring protocol that can help clinicians to rationally treat patients, especially in the middle and the long term. Remember that some patients may have a very, very prolonged depletion of B cells, but just 1 dose may stay without B cells for up to 8 or 10 months. And this is important because we must simultaneously avoid under immunosuppression, looking at resistance and escape, or over immunosuppression that may occur in more than 1/4 of patients, and that can generate in patients a persistent immunoglobulin deficiency with time, and a sort of acquired immunodeficiency, permanent immunodeficiency after treatment. So we can have some patient stories just to simulate anecdotically what can happen in this type of process of monitoring. So this is a case of a patient with membranous glomerulonephritis that had a treatment with rituximab 1 year before, and good remission, experienced a good remission, but some years after, the proteinuria reappeared, and the checking showed a sizable fraction of B cells quite in the active, mature IgG producing pattern. So this suggested the clinician to have another cycle of rituximab, after which B cells stayed at very, very low level for many, many months. And slowly the proteinuria reduced, and after a couple of years of monitoring, B cells are at the lower level, memory B cells are at lower level, and especially the memory IgM cells seem to prevail. This is quite anecdotal and happy hand story, but we also must take into account some other stories with bad outcome. And this is a patient that was treated for a Sjogren's syndrome-related follicular lymphoma. Well, not exactly an autoimmune disorder, but the case is still interesting. In October 2020, she received the last dose, and after 1 month, she caught a SARS-CoV-2 infection. And the molecular RNA swab remained positive for months. And what happened to this patient? She had no B cells, so she was totally unable to develop anti-SARS-CoV-2 antibodies. And she stayed in such a situation for many months. And she beautifully kept the anti-ABV antibodies that are witnessing the previous challenge with EBV in recent years. And demonstrating very beautifully how the memory, long-term memory, can be preserved, whereas the short-term and new antigen memory is very difficult to be developed in such an instance. So we must be very careful because therapies targeting B cells can account for drug-related secondary antibody deficiencies, and some patients may require permanent replacement therapy with immunoglobulins. And one researcher has calculated that secondary drug-related immunodeficiencies are now 30 times more common in the general population than primary immunodeficiencies. So we must be very, very cautious. So many open questions, of course, are still present. So our small study group of rheumatoid arthritis patients was composed by very heterogeneous subjects photographed at various time points of their clinical story. What we need today is a prospective study with the predefined time points for analysis in homogeneous patients. So we can learn a lot about this type of process that is, of course, very, very challenging and very difficult to perform. Moreover, we must see what is the exact value of memory B cells expressing IgM or IgG in the clinical practice and in the different diseases. But we are confident that the ISCA immune monitoring protocol may work equally well with all types of anti-CD20 monoclonals, and maybe could be the ancestor of other maybe immune monitoring protocols when the proper antibody and the proper cell target are selected. And to conclude, the Flow laboratory is usually engaged with traditional partners like hematologists, immunologists, and rheumatologists. But now the widespread usage of Rituximab has forced the laboratory to interact with many other medical specialists, some of them that cannot be very familiar with biological subtleties, and they simply need our help. So we must stay in touch with our clinical colleagues and be of help. So this is the message I can leave you, and I thank you very, very much for your attention.
Thank you very much, Dr. Brando. That last slide that you showed is actually something that I first saw at ESCA, and is just one of my favorite descriptions of what the purpose of the Flow Lab will be in the future and how much it has evolved over the years to fill this role. So anyone watching on YouTube, please feel free to put your questions in the chat if you have any. We do have a couple for you actually already. So the first one is, have you been able to specifically study secondary non-response to anti-CD20 therapies in these patients using flow cytometry, and has flow cytometry helped, that monitoring specifically helped with understanding secondary non-response?
Secondary non-response. It's a good question, because some patients may appear clinically resistant to anti-CD20. Sometimes it's the disease itself that is resistant, namely the medical literature reports that systemic lupus erythematosus is a very hard disease and hard to tackle, and maybe the mechanisms involved in the disease itself can be of some type of biological resistance to this agent, so they may require different approaches. And the patients receiving anti-CD20 can immunize against the idiotype portion of the molecule, and this is calculated around 25% of patients receiving the first rituximab dose may do so. Well, the immunization doesn't imply necessarily that the effect is diminished. Sometimes such antibodies are inhibitory, sometimes they are not. It is another complication that should be checked if you have a laboratory able to perform the ELISA testings for this type of analysis. And also nephrological patients with massive proteinuria, they have a very, very quick clearance of anti-CD20 like any other endogenous IgG. So nephrotic patients may require additional care because they may simply eliminate with their urine the antibody we are administering by vein. So there are several mechanisms of resistance that we must be very aware of.
No, thank you. And that actually leads into the second question. So you've shown very well in just your talk today that standardized, highly sensitive flow cytometry is an effective way to evaluate the relapse risk among Rituximab patients. What is your opinion on taking this maybe one step further, or maybe it's already been done, and using it for potentially intelligent dosing so that the drug is actually dosed based on their baseline?
Well, the need to develop this protocol was to help colleagues that were absolutely lost in the desert, because they are instructed to do the attack therapy, but they are left alone in the middle and the long term. So we thought about this protocol because we were asked, please, what have I to do now? Because nobody really knows what to do maybe in neurological disease or maybe optic nerve disease. And you may find people very happy of the early effect of the antibody, but very in trouble when looking at the long-term strategy. So we would be very happy to have this chapter solved in the recent months or of years, and especially to spread this type of approach into the all clinical contexts. Maybe more than that is maybe advisable, is a dream at the moment. So I have no idea of what can happen. I just can mention that maybe just one molecule cannot be enough for such a complex disease like autoimmunity. So maybe multiple needles should be put into the right gear to stop the mechanism, but maybe just one needle is not enough.
Yeah, like you said, it may end up being the ancestor of future protocols, right, for other therapies. So another question is, how many labs do you know of are currently following this protocol, and have they expressed any common pitfalls when they're starting to integrate it?
In our country, we have made a big effort during the last couple of years to disseminate this knowledge. I saw rheumatologists and nephrologists as the more sensitive to this protocol, and they have implemented this protocol into their own laboratories. But we still act as a sort of a reference lab because we were the first to devise this protocol. And this is currently ordered by physicians, both for inpatients and outpatients, and it is considered as an ordinary flow-cytometric technique based on 8 markers. That is the maximum payable performance in our hospitals. So it is now routine. The point is how to interpret every single case is another pair of shoes.
All right. How were you able to get clinicians aware? How were you able to raise awareness that this test is available?
It's the opposite. So they come to the lab asking advice and help, and they talk with their colleagues and they do the same. So we have done an incredible number of webinars and seminars and courses on that. So we are confident that the knowledge and the education has been disseminated. like any other innovation, may require time to become into a routine, and especially waiting for more consistent results in the long term. I mentioned the need to make prospective trials with homogeneous patients, with homogeneous time points, to try to understand a little more than we know today.
Okay. One last question. How long does the sample last at 4 degrees Celsius? If you're not keeping it at room temp and you are storing?
We wondered if the preservation of samples could be a practical option, but unfortunately, surface immunoglobulins are very delicate, and we recommend using a fresh sample to be processed immediately by bulk lysis. This is maybe a sort of a mandatory requirement in order to have the maximum sensitivity, because cell subsets are very small, and fluorescence intensities that you can have noticed are not very, very bright. So be quick, be gentle, and don't preserve the sample too much.
All right, one more popped in. Have you shown utility of this in leukemia and lymphoma as well?
It's another story, because in leukemia and lymphoma, you have a different problem, that is the stoichiometry between the antibody and the tumor mass you must challenge. So in leukemia and lymphoma, you may face a big discrepancy between the number of molecules of anti-CD20 that you inject and the enormous bulk of leukemia or lymphoma cells to be tagged. So in some cases, you must have an evaluation of the total tumor burden in order to recalculate the exact dose of rituximab to be administered. And there are several papers indicating that. So, as you know, oncologists treat like 375 milligrams per square meter. That's all. But if you've got a tumor like this, or like a watermelon, the relationship between the monoclonal antibody and the tumor mass may change remarkably. Also, the Fc receptor state can be of relevance. So the same approach could be applied not as repopulation, because repopulation can be easily seen with the usual oncology indicators, rather than to provide the right dose in terms of the coverage of the tumor mass. That's another point.
All right, very good. So with that, I think what we will do is move over to one of the labs that has been partnering with Dr. Brando's lab in this exact protocol, is the lab that Fransesco Buccisano, who's our next speaker, works in. So I'm going to take time to introduce him for his first talk, which is Life in Flow Cytometry Lab in the COVID-19 Era, New Risks and New Challenges. But before I do that, let's give you, Dr. Brando, just another round of applause. Thank you so much for such a detailed talk. It's very good. Have a good evening. All right, so Dr. Fransesco Buccisano is the Associate Professor of Hematology at the Department of Biomedicine and Prevention in the University of Rome Tor Vergata. He's in charge of the molecular treatment of acute leukemia unit and of the morphology and flow cytometry section of hematology laboratory, directed by Professor Francesco Lococo. His career has been focused on two major topics: the treatment of hematological malignancies and the development of multi-parametric flow cytometry applications in diagnosis and clinical research. In the 20 years since he started his work, he has observed major changes in diagnosis, treatment, and eventually the outcome of hematological patients. Flow cytometry is has played a major contribution in this process through the identification of markers that are suitable for drug delivery, the monitoring of minimal residual disease in leukemia and lymphoma and myeloma. His efforts as a clinician and a flow cytometrist strengthen the link between academic research, pharmaceutical companies, and biotech industries in the search of new biomarkers and possible therapeutic targets. So Dr. Buccisano, thank you for joining us.
Okay, thank you, Marcia. I'm sharing my screen.
And I'll let you know as soon as we see it.
Yeah.
Yep, it's good.
Okay, thank you very much. As you have heard, my background is not a lab background. I mean, I'm a clinician, but I've been struck by flow cytometry many years ago. So now I'm also I would say, an old flow cytometrist. And today I will talk about biosafety. That is a very important issue affecting our daily activities due to this pandemic. I would like to start showing you the Italian COVID timeline. I think every country has its own timeline, but this is ours. We had rumors, as all of you, on mid-December 2019 of a cluster of viral pneumonia in a very far away region of China. On mid-January, China shared the genetic sequence of the virus, so anxiety was growing. And on February 11th, the World Health Organization officially named it COVID-19 disease. So in Italy, we diagnosed our first cases on February 21st of 2020. A young man called Mattia, living near Milan, that after a remarkable amount of social activities was diagnosed having COVID. He was the first. And then things became hectic, as you know. On March 11th, a pandemic was declared. This is only to give you the idea how short was the time frame that COVID used to struck us with this emergency. And in our labs, we were particularly conditioned by two colliding forces. First of all, multiparametric flow cytometry became a pivotal technique in monitoring COVID patients. But on the other side, we had to keep going in our daily activity. I work in a hematological lab, so we manage minimal residual diseases, diagnosis of hematological malignancies. This prompted us at reviewing completely all our standard operating procedure. And this is a problem that affected labs worldwide, both simple labs, but mainly core facilities. As you can see in the right part of the slide, maybe this is a bit self-celebratory, but in this review, Chattopadhyay and co-authors on behalf of ISAC show how cytometry is currently at the very center of the fight against COVID. Because it may contribute to many fields of research, clinical management of patients, and vaccine development. But the only proper way to exploit is huge power in performing these activities is to comply with several rules: sample processing, translation into cleaning, data sharing, and mostly biosafety. First of all, a bit of glossary. We are talking about biosecurity and biosafety. It's like talking about strategy and tactics. Biosecurity is a strategy, an integrated approach whose purpose is analyze and manage relevant risks to human, animal, and plant life. And we are sadly aware how stressed ecosystems may have contributed to the spillover of coronavirus to humans. So biosecurity is a measure to prevent, control, and manage risk to life and health, and it deploys rules that are different according if you are talking about humans, animals, obviously, and plants. Biosafety is the daily tactic, is what helps us in avoiding at the beginning only a large loss of biological integrity. Today is a tool in focusing on ecology, human health, and relies on mechanisms that are based on regular reviews of biosafety rules and procedures in our labs. Since the beginning of COVID, many guidelines have been released. I show you in this slide the most important one probably, but by the WHO and the CDC. But almost every society, also in the flow-cytometric world, like ISAC, have released very interesting guidelines that now are our main reference. But I think that the approach to biosafety in our lab should be critical in this way. We have to carefully analyze the three major role players in this situation. Agent is a virus in this case, but is also a toxic compound, some other dangerous and harmful agents, and the agent is usually contaminating a sample. The second player is the human resources, and that are considered not only people operating in the lab, but also people around the lab, carrying the sample, coming to take the report at the end of the analytical process. The third role player is the test that is requested to the lab and the instrument that we use to perform it. What I think is critical is the approach and the analysis of risk. This is the SWOT analysis. Many of you probably are familiar with this because this is the core of several accreditation systems. For instance, in Europe, UNI and ISO 2015 is based on a risk assessment that's and SWOT analysis is the mean that allow us to perform this. Briefly, we have to you have to consider all external and internal factors to your organization and to your process, your lab in this case, and try to understand if they are helpful or harmful to the development, this execution of your process. This ends out in producing a classification of strengths, weaknesses, opportunities, and threats. This is a useful process because it allows to put guidelines into your own context and transform guidelines that probably are whose purpose is probably to be open to the world, to translate guidelines into your standard operating procedures. And this is not a static process, but it's a dynamic one, following the concept of the plan, do, check, act cycle. First of all, you have to perform your risk analysis, describe work activities, identify hazards, and determine risks. If the risk-benefit ratio is acceptable, you can start your process. If not, you can quit, but I think this is not an option, particularly in when dealing with COVID or hematological malignancies. So we have to prepare a risk control action plan, implement control measures, review the adequacy of the plan, and then check again the risk-benefit ratio. If yes, we can proceed. If no, we have to go round and round this circle, trying to guarantee an improvement of our processes and our safety measures. Let's look a bit into more detail inherent risk of SARS-CoV-2. The presence of the virus has been demonstrated in many specimens, bronchoalveolar lavage fluid, sputum, nasopharyngeal swabs, feces, blood, and urine by RT-qPCR. So this is something very reliable. But finding viral RNA in a fluid does not mean that it is that it has the original length, and mostly that it is able to allow the building of a new viral capsid, for instance. No solid information are available about the detection of SARS-CoV-2 in blood, nor the real meaning of the RNA, viral RNA that has been demonstrated to be in plasma, in human plasma. Regarding the stability of the virus on various surfaces, there is plenty of literature, and we know that it can survive minutes to days according to the different surfaces, wood, stainless steel, plastic, and so on. What about human resources inherent risk? I think this is the aspect that has been changed most by the COVID, because in the pre-COVID era, we were focused on the sample and the technical personnel managing the sample, handling the sample. So the standard mitigation approach was a detailed sample-associated biological safety assessment. So engineering control, adoption of personal preventive efforts, and standard operating procedure for processing and analyzing samples were all the most important thing we have to deal with. In the COVID era, the concept of human resources and risk carried by human resources has changed a lot, because we have to include in our biosafety risk assessment not only the people of the lab that probably are the most aware of the danger, but also staff users, external visitors, people who carries the sample. So we have to identify, together with the upper level at our hospital, the workforce with potential for exposure, characterize the risk, monitor it, and possibly mitigate it. Okay, so this has become a matter of health security again. What about instruments? We have realized that we are working assuming that all human specimens coming into our lab are potentially at risk. So protective measures have been implemented to reduce the risk of transmission, whatever the sample accessing the laboratory. So these precautions include the use of barriers like hand hygiene, gloves, gowns, facial masks, protective eyewear, face masks, and shields. So it's important to consider that all non-propagative laboratory work should be performed at a biosafety level 2. I will show you what it is. Probably you already know it. But if procedures are likely to result in a higher risk of transmission, for instance, sorting procedures, probably the level of biosafety risk should be enhanced. And in some situation, the instrument itself is embedded in a biological safety cabinet or protected by a physical barrier. This is the cabinet I was mentioned. Class 2 cabinets have been designed to protect the sample and the environment, because the key feature of these cabinets is the recirculation of air. So we can identify, as you can see in this cartoon, the place of the cabinet where it's safe to handle hazardous materials, the red ones. This is all a matter of air circulation. Okay, so I think that we have to suggest when dealing with the COVID patient samples to adopt the use of a class 2 cabinet B2 or C1, as you can see depicted in the slide. As I told you, sometimes today we have very short and time and space sparing instruments, so they can even be included into a biosafety cabinet to minimize the risk for the rest of the lab. Procedures with a high likelihood of generating droplets or aerosol should be handled in a biosafety level 2 or 2+ or biosafety level 2/3. You can see a nice table summarizing what the difference are between these 3 levels. Basically, the difference is about how often the protection is renewed and checked. Aerosol containment, for instance, is monthly in a biosafety level 2, but is after each procedures in a biosafety level 2/3. TIEC suits, the full body ones, are not required in biosafety level 2, but are mandatory in biosafety level 3. For instance, lab gown, closed in front, are required in all 3 situations, but in, for instance, biosafety level 3, we have to wear a TIEC suit, for instance. Leather gloves, single or double, are also different according to the different level, and the respiratory protection that can be considered optional in biosafety level 2 is mandatory in when we raise the level of surveillance. As I told you, cell sorting that luckily is not a routinary activity in many labs, but is restricted to some reference center, but has been a fundamental tool of development, for instance, of vaccine approach to COVID and other infectious disease. Should be probably is the procedure with the higher risk of contamination. So there is a specific ISAC biosafety guidelines, standard operating procedure for it. This is only to show you that probably together with working at a biosafety level of 2+ or 3, there are also additional items like this. As shown in this picture, there is a further containment or aerosol that actually protect the sorting chamber. So this is something very important when performing this kind of procedure. When we use standard analyzer, so no sorting procedures, that probably is our daily activity. The use of this kind of procedure is considered to be at low risk due to probably the closed systems and the low pressure involved in this analysis. However, there is a counterbalancement because they have an uncharacterized risk because are operated by a larger number of users with varying level of experience, trainees, and so on. So training of personnel and communication and dissemination of the standard operating procedures is mandatory in this kind of situation. This is the ideal process, step-by-step process of a routine acquisition of COVID-19 samples, or probably is not proper to say only COVID samples, because as I told you, in these hard times, we have to consider every sample to be at risk of COVID. Try to imagine a sample coming for a suspect acute leukemia and diagnose it in the emergency room. We usually consider this sample to be at risk. So the first recommendation is to choose an approach that probably is not involving, for instance, a PBMC separation to work on the whole blood. Staining should be performed in a class 2 biosafety cabin in a BCL2 lab. The personal protective equipment, PPE, should be coat, gloves, surgical mask, and eye protection. Incubation obviously is not a moment where the sample is handled by the personnel, but probably it should be performed in the same environment, biosafety cabinet, class 2 in a BLS2 lab. Washing is a decisive step because the sample is moved into a centrifuge. Centrifuge should be kept equipped with capped buckets and placed in the same BLS2 environment. The PPE are the same. Lice no wash procedure is suggested in this situation. Fixation, again, is a very crucial phase of sample processing because fixation is the moment when we have the chance to inactivate the virus. So the environment is the same, the PPE are the same, but fixative solutions should be carefully selected. They should be CE-IVD qualified and are listed in several of the guidelines that I've shown you. Acquisition included the phase of uploading and removal of the REX from the instrument. Should be performed by personnel with a careful equipment of personal protective items, and the cytometer should be placed in a BSL2 lab, as I told you. As you know, the combination of integrated closed system like the one showed in the slide, together with the lice no wash technique, probably put the operators in the most safe position. These systems are equipped with separate access to sample for the sample loader, different access for the rack loader, and the reagent loader and fluidics are managed separately. So we can, provided we had an unequivocal sample identification, we are able to safely perform the analysis until the reporting. For all labs not using a closed system, we have several recommendations. There are some key points that should be observed and obtained to be on the safe risk. So the suggestion is always perform pre-analytical phase under a biosafety cabinet of second class. Use activated solution possibly in a lice no wash procedures to minimize the handling of the sample. If not a closed system, the instrument should be equipped with a closed rack loader. This is important when the acquisition is fulfilled, is ended, is complete. The suggestion is to wait an appropriate time to allow droplets deposition before opening the rack loader. And then we can start wasting disposal procedure. This is the final phase, but it's crucial because it's the final inactivation of all the fluids and the leftover of the samples that we have at the end of our procedure. So after the acquisition, wash the cytometer according to the manufacturer procedure. Again, I recommend to wait an appropriate time that may be up to 60 minutes to allow droplet deposition before opening the rack loader. Then the entire working area is cleaned up using sodium hypochlorite or 70% ethanol. Disposable materials are discarded into appropriate biohazard containers, and all work surfaces must be wiped off. The recommendation of WHO over ISAC, for instance, state that waste containers should hold enough bleach to result in a final 10% concentration, and this is another hint I can give you to allow a safe waste disposal even after the waste exit the laboratory. This is my final slide. Flow cytometry as a pivotal role in clinical monitoring of COVID-19 patients and supporting research in this field. But we also have the problem to carry on our routine analysis in diagnosis and management of hematological patients. So we are actually in the center of the storm. So flow cytometry application to COVID-19 contaminated sample has prompted relevant changes in our daily laboratory routine. Biological safety assessment need to consider not only sample and reagents, but also lab staff, user, and visitors as potential carrier of risk for the lab. The suggestion for the organization is that perform a continual improvement of the control of biohazard control following a plan, do, check, act approach, facilitating a safety conversation and communication between users should be the foundation of safety within the lab. My last slide is to acknowledge FlowTex for the kind invitation and the people from my lab that is currently directed by Maria Teresa Boso, in particular Daniela Frabboni, that is my brave colleagues that is in charge of biosafety, and it also transmitted to me what I've tried to explain you and suggest to you today. Thank you. This is my last slide, and I'll be happy to take questions if there are.
All right. So thank you very much, Dr. Buccisano. We have actually got quite a few questions in. The first is there any approach to monitor lab-acquired infections when community spread is reduced? And will this need, or is this need, increased in patients who have cancer or other immunocompromised conditions who may not clear the virus as efficiently?
We have if I understand well the question, there is a plan to monitor possible laboratory acquired infection. That is a part of the personnel monitoring in our hospital, who actually is a COVID reference hospital. So we have received our vaccine, but in the past we have been monitoring quite strictly, I can say, by nasopharyngeal swab or stab, if you want. So it was not a pleasure, but it was performed to guarantee safety also of interpersonal transmission in the lab and in the clinical world. As a clinical hematologist, I can tell you that the problem of COVID infection is relevant in hematological patients because they have impaired immune defenses. So they have a much higher risk of death of COVID infection that actually is estimated to be of more than 1/3 of patient testing positive, regardless of the specific hematological disease they are affected by. So it's a major problem, and we had to organize also the access to our outpatient clinic in a proper way, also the admission in our inpatient ward with a very strict monitoring of nasopharyngeal swab. And I think that we have done a pretty good job worldwide as hematologists, but the problem is indeed relevant because, you know, mortality is very high.
Yeah, and it might be a little harder than maybe monitoring a blood-borne pathogen or sexually transmitted disease. It's kind of like asking the question, you know, would we be able to monitor laboratory-acquired flu? I just think it's maybe a little more complex because it is an airborne disease. So I think that that might, you know, be a little asterisk compared to what we've normally in the past thought of when we think of laboratory-acquired infection. So,
I'm not a bit an infectious disease specialist, but I think that I know the airborne transmission is a possibility. I think that it's a mixture of contact and airborne transmission, because if you consider droplets are the main tool used by the virus to spread. I think that we can manage it with social distancing and with masks and the approach that I've described in our lab. Something has changed very deeply in our normal behavior, even at work.
Yeah, very good. So the next question starts off just by thanking you for the really nice setup in talking about the Class 2 cabinet, but then asks specifically, when it comes to protecting the operator or the technician, would a Class 1 cabinet suffice? And if not, why?
The question is why Class 1 is not considered appropriate to manage COVID samples. I think the main difference between Class 1 and Class 2 is the circulation of air and the filters that are applied to air flushing into the cab. So generally speaking, Class 2 is the gold standard. Obviously, we have to consider that such a huge audience like the one of FlowTex may have different lab situations. So probably someone of the colleagues is actually working in a Class 1. So I think that with a Class 1 cabinet. So even if not appropriate, I think that the suggestion I can give is that personal protective equipment put the technician or the operator on the safe side. Because at the end of the story, laboratory-acquired infection are not often reported even in the COVID era. So I think that probably the adoption of PPE, appropriate PPE, is a good way to avoid the transmission of the infection. But I think that, at the end of the story, I don't think laboratory-acquired infection are a major problem with COVID.
Okay. Did you experience any shortage in PPE or biosafety cabinets? How would you prioritize which patient samples require higher protection?
It's hard for me to answer this question because we have not performed analysis on other than blood. Because, for instance, bronchoalveolar lavage, that is a very important source of infection, is probably one of the samples that put more at risk the personnel, also the medical personnel performing the bronchoscopy, but also, for instance, lab people opening the labs. So I think that tissues where we know that the virus is located, like everything pertaining, for instance, the lung, is at higher risk. As I told you, as I showed you, probably blood is not an high risk tissue, but I think that the procedure, the flow-cytometric analysis, may transform it in a sample at risk due to the generation of aerosols. So you have to consider the process in the whole, from the beginning to end. So finally, answering to your question, I think that we have excluded analysis on bronchoalveolar lavage and prioritized blood. With our approach and our closed system, we were able to perform analysis on every kind of patient. So we weren't forced to make any distinction. And we were quite proud for having carried on several diagnoses, first diagnosis in patients entering the emergency room for COVID disease, but at the end coming up with a diagnosis of leukemia or lymphoma. I think you are on mute.
I did put myself on mute. Thanks for catching that. So the next question is, when operating analyzers, would vortexing samples be considered aerosol generating and therefore require special handling?
Absolutely, yes. Vortexing vortexing and sorting are the two phases of sample handling and management that generates aerosol. So, beside wearing, I repeat again, the appropriate PPE, I think that is safe to perform all the phases of sample processing in a biosafety cabinet of Class 2.
Okay. 2 more left. Do biosafety requirements change when sorting convalescent samples versus samples with a high viral load, or do any human samples require the same level of containment?
I've not a personal experience on this because we are not actually performing sorting. What I can tell you is that to stay on the safe side, every sorting procedure according to guidelines has to be considered to be at high risk. So no different between convalescents, and even on the clinical ground, we are aware that they are different phase of disease. So the biohazard is different, but I think that to stay on the safe side, we have to be careful and perform consider the procedure at high risk, regardless of the clinical phase of disease.
Is there any protocol to be sure you've waited long enough to open the loader or evacuation of loader to HEPA as we use it in, I don't know what the last thing is. I can't read it.
Okay, let me.
Probably as we use in the lab.
Yeah, but because I have not opened the YouTube chat, so it's up to you. I'm sorry.
No, I'm getting it.
I can't help you.
As they use it in sorters. So is there any protocol to be sure you've waited long enough to open the loader or evacuation of loader to HEPA as we use in sorters?
I think that this. Sorry, Marsha, go on.
Yeah, they're just basically referencing that there is a protocol in sorters.
This is the typical situation I mentioned where guidelines should be put in the context of your lab and become your own SOP. Because SOP are specific of each laboratory, of each, for instance, the placement in the room of the cytometer, the air circulation in the lab. There is not a pre-designed time, but I think that it should be adopted a time of guarantee that can be, I would say 1 hour, but it's also to be put in the context of the amount of daily activity. So it can be shortened or even become longer according to the specific situation of the moment. Again, we have to put this suggestion in the context and the routine of our specific lab.
Yeah.
Sorry, Marsha, the longer the better, just to give a final sentence, the final question to your answer.
Okay, the longer the better, but no specified amount of time, like
No.
a full minute. Yeah. Okay.
I would say up to 1 hour. It means that it can be from 50 minutes, I would say, up to an hour.
Wow. All right. So change management, just my personal last question, change management on things like this, are there tips or tricks Or is it as simple as actually writing and posting a protocol? Are a lot of people pretty open to those things, or even at the administrative level, are there, resistance to some of the things that you request?
As you can easily imagine, a huge university hospital is not very flexible in accepting changes and requirements from the specific lab. Our luck was that becoming a COVID reference center, probably all their efforts were toward COVID. So we've been all our wishes became true. So in our specific situation, we were able to change. The culture of quality assessment and biosafety is part of this. Is something that luckily we have in our hospital since at least 2 decades. So I think we were lucky, but I can understand that in some other situation it can be really, really hard. A simple thing, just to close the lab, that usually, because we work in close contact with our colleague hematologists, and just the situation when we say, no, you can enter the lab from now on, it was a kind of trauma. So it was not easy, but we have to do it.
Yes. Well, first and foremost, I want to thank you for this excellent talk. I see that Bruno is still with us, Dr. Brando. And if he's able to put his camera back on, I'll ask him to. If not, I'll just continue and say to our audience that's joined us by YouTube, thank you for joining. Most of you who come to this every year know that we have 3 talks. That 3rd talk is coming up. And at the end of this, I will make sure to remind you how to get into that talk. But before I do that, I just really want to thank Dr. Buccisano and Dr. Brando. We certainly have had an overarching emphasis, meaning that our speakers are from Italy. You guys have done a fantastic job leading during these COVID times, and we just feel really fortunate to have had you with us today. Know that our hearts are with you, and we really appreciate you joining us this evening and sharing just such vital information with us. So we are about ready to go into about a 20-minute break. Between now and then, make sure you get on the science webinar link. That is where we will have the 3rd discussion, which those of you who are viewing were actually pivotal in making sure we had the first discussion early in COVID as a science webinar, looking at the role of the T cell in severity for COVID-19. Dr. Buccisano will join us there again with his collaborator, Dr. Iannetta, and we will see you there in about 15 minutes.
Thank you.
Okay, thank you. Thank you, Marcia. I'll jump into the other platform.